just the other day, I saw in the Oregonian that they were leaking the new healthcare expenditures figures that aren't out yet in the journal, and they were publishing the current numbers. So, and that's thanks to you all. That's thanks to your showing up at meetings like this and saying, I'm interested in healthcare. This is important to me. I'm not going to let things slide, because the politicians actually have been lying to us historically. They've been lying to us because we're not paying attention. Does anybody remember a politician who told us there are no access problems in America, in the American healthcare sector, because, does anybody remember why there's no access problems? Because you can just go to the ER. You just always walk into the ER and you get the healthcare you need. Now, people are educating themselves. They're going, wait a minute, access is much more complicated than that. You can't say that. Another one that was a politician just recently who said, we have the highest quality of healthcare in the world. And people are going, well, wait a minute, people aren't demonstrating that. It's good, but it's not that much better than other economically developed countries. But I didn't come here because I wanted to lecture for the whole time, and I've talked too long, obviously. What I want to do is hear what you guys are thinking, and hear your questions. So
I'll just slit your own throat. I had a colleague of mine who once said that sociology was one of the complex sciences, which was sort of his way of saying that we weren't terribly helpful because we didn't really provide him with any concrete answers. And my response to that was, well, yes, but the job is to provide as much information as possible and then let people decide for themselves and actually do the analysis themselves. And I think that's one of the things that, sort of piggybacking on what Mick was talking about, that reminds me about this panel, is that they're providing a lot of different perspectives for us today, and that are coming from different points of view and different experiences and even sort of different sources of data. And I think that's one of the things to remember, is that it's up to you to ask those questions and to ask good questions. And then it's also up to you to decide what you're going to do with that. And so what we'd like to do next is have you take I think you've been given some cards, and if you have a question that you would like to ask the panel, then why don't you pass it to the center aisle, or you can bring it to me. And we're going to take about a 10-minute break or so and let you get some refreshments in the back, and then we'll let the panel decide who has to go first, I guess. And there's also a place in the back here if you want to write down your name and your email if you'd like to get further information and further notices. I think the reason I don't have it is because Mick took the paper for his notes. So,
practitioner from 1925 to 1965. And I saw him every Tuesday morning for breakfast. Before he went on his rounds, he talked about things going on in his practice. And one of the things that he used to say to us, a little story that came up again and again was, I had a patient in the other day, and it was really difficult because I had to give him a diagnosis of whatever. And the funny thing is, the thing he was worried the most about was money. And so I told him, don't you worry, we're going to do everything we can for you, and we'll worry about paying for it later. Now, the reason I tell you that story is because until 1965, when he quit practicing medicine, when he retired, you could say that. I mean, I want you to think about the fundamentally different ethical issues we are dealing with today than we were when I was a child, which is that we can spend $12 million on your health care. We can, and it will make you live longer. The values question that I want us to consider as we think about these issues is, should we spend $12 million on someone's health care, on someone's health care? Should we? And if not, if we are not going to, or should it be, well, we will if they have a job and good insurance, and we won't if they don't. So I just want to keep, I'm pitching in here because I didn't get any questions, which is great. It just means you all agree with what I said. But which is that I do not read in newspaper articles or in other aspects of this debate about the values question, which faces the reality that we can spend everything we have on one person's life. And is that a legitimate ethical decision to make? And if so, or not, how do we make that decision? Do we just let that simply be done by who's got the bucks and what do they want to spend it on? So anyway, thanks.
Steve, that sounds like a question for the dismal science.
Yes.
And, you know, the dismal science that economists are really stupid. And in one way that they're stupid is that they like to say, oh, econ is so mathy, you can't understand it. And it's really, that's weird because there's a lot of other disciplines where they use even heavier duty math. And so why would they say that? Well, they use different notation so that a mathematician would look at it and go, what the heck is this? So they go, oh, it's real mathy, you couldn't understand it. But really, it's stupid that they're doing that because I think it excludes people from the discussion, and really just because something can be explained mathematically doesn't mean that it can't be understood without math. And the underlying issue here with that you brought up, that spending all our money on the one guy, is part of demand theory. And economists always say, oh, demand theory is so complicated you couldn't understand it. And here it is with no math. All economists believe this is true, so it doesn't matter whether you believe it's true or not. The thing that's important is they all believe it. And that is that if you have something of value, a good or service of value, as the price of that thing goes down, the demand for it's going to go up. And as the price approaches zero, the demand will approach infinity. So if you want to say every person in America, regardless of anything and ability to pay, should have the right to receive whatever services or goods that will possibly increase their psychosocial well-being, then we should pay for it. Well, what that's going to do is cause the demand for healthcare services to exceed GDP. They will explode out of control. Now, we saw this happen with Medicare Part A when they first made it a new program for hospital stuff. They told the hospitals, just keep track of your costs, and then we'll use your cost reports and figure out how much you'll get paid. And so the hospitals kept track of all their costs, and they kept sending it to the Healthcare Financing Administration, and they said, wait a minute, we're spending so much, we're going to spend more money than there is in the universe on this hospital stuff. We can't do cost-based reimbursement. We'll do this prospective reimbursement, PPS, it's boring, but we've got to have a way to control costs. So you can kind of think of the demand monster. Economists believe in the demand monster, and if you're not careful, the demand monster will come and take everything away from you. And that's the one guy using all the resources. That's the demand monster. Okay, that's all the demand theory there is. There was a question here about what extent do undocumented people lead to increasing healthcare costs, and that is related to the demand monster. If we created a system that said anybody that's walking and breathing in this country gets the best healthcare that we can provide, well, folks come to this country on tourist visas and stay until they get tired and then they go home. And if they hear that all they have to do is arrive with a tourist visa and they can walk in and get the best healthcare that the U.S. has to offer, then that's the demand monster. That's one way that you'll create the demand monster that will, the demand for healthcare services will immediately exceed any possible supply. So clearly, if there's going to be a healthcare benefit that's inclusive to everybody, then you need some sort of way to figure out who's a citizen and who's entitled to it, because there's no way that we'll be able to provide healthcare to everybody on the planet who can scrape up a one-way ticket to this country.
So that actually did occur for a period of time in which we had folks over 65 with their Medicare benefit that did not have any prescription drugs. They were traveling over the borders to both Mexico and Canada to get their prescription drugs because it was a lot cheaper and they could, get access to it. So in this case, I guess we were lucky that Canada and Mexico allowed that to happen, right?
So why don't we alternate if you guys have divided it up amongst you so that maybe someone else can, do you have questions to answer?